everybody. We're here today with the director of the Danish Multiple Sclerosis Registry, Professor Melinda Magyari. Melinda, welcome.
Thank you so much. Thank you for inviting me.
Melinda, what is PIRA?
PIRA stands for Progression Independent of Relapse Activity. It's an outcome we heard about the last couple of years. So it describes the disability accumulation that occurs outside the clinical relapses. So it is important because now we understand how long-term disability develops through silent progresses and not the relapse-related worsening.
How does PIRA differ from the traditional understanding of MS progression?
As traditionally, we have been focusing on clinical relapsing with full or partially remission and MRI lesion because we assume that drive disability accumulation. We now know that relapses add about 15-20% to the disability accumulation. So the rest is this progression that is independent of relapses. So it occurs even when the inflammatory activity seems well controlled.
At what stage of MS does PIRA occur?
As a PIRA occurs very early from the beginning of the disease, even in relapsing MS, that between relapses as a MRI and with some measures we can measure a very slight slow progression, but it becomes more prominent with longer disease duration and with age.
How is PIRA identified and measured in a clinical practice?
In clinical practice, now we are aware of it. So we measure it as a confirmed disability worsening, so by the neurological examination, by the ADSS. But we can also be aware of that with the patient-reported outcome, like questionnaires about fatigue, cognitive function, walking scales, that measures function that the ADSS is not covering. However, and we have to detangle this from the relapses.
So the most common way you notice the thing, the most common way that you are measuring things is with the EDSS score.
With the EDSS and what the patient tells us. If the patient tells us that I am getting worse, even though I can't, because we know the imperfection of the EDSS, even though I can't see it in the EDSS, that I still think that it's a relevant progression if the patient experienced it.
Okay. And is PIRA something that starts at the beginning and then it ends at what time? Does it ever end?
It doesn't end, okay. because as a MS is a lifelong disease. Mm-hmm. We don't have drug that stops or cures the disease.
Okay.
And these are very, very low-grade inflammation within the CNS. Therefore, it's called Smouldering. Okay. So it doesn't end no. Because we don't have any evidence that something... Of course, there are some patients who are stable, so it's important to remember there are individual differences.
Okay. What are the main challenges in distinguishing the relapse independent progress?
It's very important, particularly in that phase of MS when you have both relapses and progression, to separate this subtle progression from the incomplete relapse recovery.
Okay.
And also the measurement variability. And so we have to make sure that progression is progression. There is no comorbidities. There is no other stressing things happening in the patient life, no musculoskeletal issues, and no subtle relapses.
How important is PIRA for long-term disability accumulation?
Very important. Studies suggest that a large proportion of disability accumulation is driven by PIRA rather than relapses.
How does the awareness of PIRA, how is that gonna influence of your treatment decisions?
It really underscores, encourages earlier use of highly effective therapies and closer monitoring, even when the relapse activity is low.
Is there certain therapies that is in the market today that you are using and that shows that it can reduce PIRA?
As we know, some high-efficacy therapies that appear to reduce the risk. Some of are better to slow progression, likely because they suppress inflammatory processes that contribute to later neurodegeneration. But remember, most of the earlier drugs were targeting relapses. But now, also in real-world data, PIRA, it's an important outcome to measure and understand.
So is it correct that because of the treatments that are there now for the relapse, and because you have got relapses so much under control today, that this is where PIRA is kind of have started to show a lot more?
Yes.
And that this is the main thing?
Yes, because when you don't have relapses, progression is demasked, and when you solve the relapses, then you pay attention to other things. Then you suddenly see that there is a progression independent of relapses. You also, when we control relapses and new MRI lesion, they also have more resources to concentrate on this progression and to be aware, both the neurologist and the patient, to talk about it and see what can it be done. And also we hope there will be therapies that also can slow this kind of progression.
It has been in Denmark for a long time. It has been like a lot of patients have found out and have been scared of what is it that is happening in between my two relapses, what we today call PIRA. Yeah. And there has been a lot of quietness about it because you didn't want to talk to your neurologist, your doctor about it, because you didn't know how is he going to react, or is he going to take away my medicine? Is that a fear that MS patients should have today, that they might have their medication taken?
No, not today, but it's very important that we talk about so we somehow dissolve this myth, because even us neurologists, we thought that there were incomplete recovery of relapses because it was a phenotypic subclassification. You thought you have the relapsing part, and then it's coming the secondary progressive part where may can have relapses. And yes, there was all clinical trials was targeting relapses and new MRI lesion. So when it was more progressive and you didn't have an indication for medication, yes, it was it generated a lot of fear to be categorized as secondary progressive or progressive, and then ending up without any medication. There is no fear because now we have drugs. Yes. who also work for progression, and it's more and more this very, very sharp distribution between relapsing and progression starts to dissolve. We are starting to see biologically the disease as a continuum.
In the Danish MS registry, you have a part of your homepage where people can register and they can submit some forms. Yes. So you can follow them in a different way. But as a patient, as somebody who is living with MS, the more we are kind of honest, the more we are explaining about our difficulties, like you said, there are so many symptoms, so many things that affect your progression. It could be cognition, it could be a lot of different things. Openness, is that a key word from yes. MS patients to the doctor?
Absolutely, openness, and also, but I admit that doctors also should be. Openness has to come from both parts.
Yes.
Both from the patients and the doctor. Yeah. Because it's important to identify the reason. It's important also to say to the patients that that it's important with physical training. It's important to treat comorbidities. So, but when it's progression or other symptomatic things, so we can target the treatment for that.
So what you're saying is not only the treatment for MS itself, but as well for some of the symptoms yes. that are coming up, that it would be easier for you guys as the doctors to help the person with MS if the more we are open, the more we explain about our difficulties in symptoms, the easier it is for you guys to help us make a plan for not only the MS, but for all the symptoms.
Absolutely, because we know how much physical training, regular training, it's associated with the EDSS. If the patient cannot do the regular training because of pain, because of spasticity, it's important to see that and treat this pain, to have an effective treatment so the patient can have resources, time, energy to go to rehabilitation. Otherwise, it's a vicious circle.
Do you think that the communication between the doctors and the patients with the people living with MS is good enough? Or do you think we should be better on both sides, not only on your side, but on the patient side as well? Should we be better?
Yeah, I think we should be able to better communicate, to understand the real need.
Yeah.
And I think it's a big challenge because the number of MS patients in Denmark is increasing. The number of and the time what we can dedicate for the clinic is decreasing.
Exactly.
Therefore, us we have to learn to communicate that it's important, and the frequency and the depth of communication has to be individually adjusted.
Yes.
So patients who needs to communicate can communicate openly with the neurologist.
If you have to summarize a message about PIRA,
yes,
what would that be?
MS can progress silently, and absence of relapses does not mean absence of disease activity.
Okay. And if you have a good advice to people with MS that are experiencing PIRA, what would that be?
I think in some ways you have to monitor yourself, whether you do it in patient-reported outcomes, and just to be aware of your cognition, gait function, and don't give up if the neurologist is a non-responder. Just keep trying, make yourself understand, and that we hope that you will at the communication would be better. I know there are neurologists who don't use the patient-reported outcomes, when we are trying to push from our side that it's an important tool. Maybe in the current form, it's just a beginning, but in years we are trying to improve it, make it more smart, more or less time consuming, but it's going to be the future communication tool between neurologists and patients.
I think that some years ago, the government decided to have something called the doctor with responsibility of a patient.
Yes.
And that system has worked, according to us, people with MS, partly okay. It hasn't worked perfectly, but it has been partly okay. We have tried in Sclerose.info, we have tried to teach the people with MS to be responsible as patient towards the doctor. So we have kind of flipped it around. We are trying to educate the patient to be prepared for the meeting with the doctor, to be ready, to have written down all your informations or all your questions, most of the time to take a relative with you if you can. But there's no doubt that what you have on your website, the system, is absolutely amazing, and for the patients as well, because by that we give data in that the doctors can access and follow the either progression or how the development of the MS has been. So it's a very good tool you have.
Thank you. And I agree that the patient needs to take the responsibility for the disease and communicating to the doctor what's the most important thing at a certain consultation to solve.
Yes.
So it's not getting just a boring clinical routine control. I would like you to solve these two things.
Yes. And be more focused upon this. How long time does a doctor have today?
It's very different from clinic to clinic.
Okay, approximately.
For a clinical control, actually we have 45 minutes, but we also have the electronic record system. So with the years, we use a lot of time with the computer. We have to write the record. We have to order the MRIs, the lab test. Therefore, actually, in this data collection platform, now we built an auto-generating test. Yeah. Because we would like to save some more time to communicate with the patients.
Okay. So where it was less hopefully looking forward, there will be a little more time together with the doctor.
Yes.
We hope that. Melinda, we have talked about PIRA for a little bit, and you mentioned as well Smouldering MS. What is Smouldering MS?
So, Smouldering MS is associated with PIRA, but PIRA is the clinical observation. It's a symptom. It's a worsening without progression, without relapses. Smouldering MS describes the underlying biological processes that may drive the progression.
Okay. So what are the processes that are driving Smouldering MS?
So this is a chronic slow disease activity. This is a slow tissue damage. It's chronic active lesion, microglia activation, meningeal inflammation, oxidative stress, and a very slow neurodegeneration. So you can imagine it's a kind of smoldering chronic inflammation that's so that there are interconnected processes.
How does it affect the MS? It's it's a constant ongoing thing, correct?
Yes, it's a constant ongoing low-grade inflammation in the central nervous system.
Okay. Is it more common for progressive MS or is it for relapsing MS as well?
It's associated with longer disease duration.
Okay.
So with age, it increases with age.
Okay.
And also clinically, in young people, there is a compensatory mechanisms.
Okay.
While with age, that compensatory mechanism decline, so it's also more visible. It's also more clinical, and we know that this inflammation increases. It's the aging.
Yeah, it's fairly a new thing to talk about smoldering MS. It's a new thing. It's not something that they talked about 5 years ago or 10 years ago. So it's fairly new. How do you monitor it, or how is it being monitored?
It's not being monitored by MRI because everything is still in a research setting. Okay. So we need these advanced MRI markers like slowly expanding lesions, and it needs longitudinal monitoring. Okay. Some of the processes described, we still more evidence to really prove that it's like that. So smoldering MS, there are some processes, but it's a theory.
So, okay, so it's a theory, so it's not something yet we are sure about. How would you, if I came in as a patient and it comes, how do you detect that?
And so I would say at a neurologist, if you know your patients, then you also, if the patient says, I am progressing, I think I'm not, I can do a bit less, I get more tired, I walk less, I think I don't achieve the same, my thinking is a bit slower, I think my hands are, so it's a very slow functional deterioration. Okay. Then it's PIRA. And then, but you don't see it in a regular clinical MRI yet.
No, okay. And the way that we as patient notice it ourselves is, like you said, that we can notice that there's something going on. We don't know what it is, but there's something and it's strange.
Yes, but it's so slow, so you would not think it's a relapse, and it's not it can be just a little worsening bladder contour. You are more tired. Maybe you could go 2 kilometers and you can go 200 meters shorter. So it's very, but if you follow it, then maybe in 1 or 2 years you can see, okay, I can see this very slow progressing functional loss.
Is it the same thing like PIRA in the sense that when it comes to medication, that there's no differences, there's no adjustment in the treatment you're getting for MS?
If it's progression, that I think there would be possibilities to start drugs that we know that it works for progression.
Yes.
So some of the B-cell depleting therapies that has been shown some effectiveness for progression.
Okay, and that would be the same as if we look at the future, it would be that type of medicine that they will be looking at if they have a suspicion that smoldering MS is going on, that you have that inflammation going on constantly.
And so we still have a hope that BTK inhibitors.
Okay. Yeah.
Yes. So even though there has been some mixed results, but we hope that some BTK inhibitors would show, and there has been some BTK inhibitors showed effectiveness in the progressive phenotypes.
Yes.
So we still have a hope that they will be on the market for patients to target progression.
Like with PIRA, do you have a specific message that is important to tell people with MS about smoldering MS?
Yes, and I think just to get to the therapy. So yes, we have the BTK inhibitors, but also we really hope there coming some treatment targeting the neuroprotection and the remyelination.
Yeah.
But the most important message right now for people with MS. So even if the disease seems quiet, ongoing monitoring and treatment remain is important. So keep the contact with the clinic and monitor yourself, whether you do it with wearables. Of course, I would like you do it with PRO, the patient-reported outcome. And we are building the website, so it's going to be more smart and easy. But just monitor yourself to have some documentation that you are getting worse.
How many people today are being treated for their MS?
So we have 19,512 people living with MS in Denmark today, and it's about 9,600 who are on treatment. So it's about half.
Is that good enough, Melinda?
It is good enough because the reason why we have half of them, when you see the age distribution, you can see at we have patients who had MS for 50, 60 years, and those patients never had the chance to get treatment. So by the proportion is so little because we register everyone. We have over 100 people living with MS who are over 90 years old.
Yeah.
So therefore, I really hope that today all patients where we have a hope that treatment would help are on treatment.
There are stories still being told about that it's better not to be treated because there are so many side effects by the different treatments. And that if you just eat correctly and you have a healthy life, that this will be enough.
I really support every kind of diet, complementary treatment, but I think you have to do both. So because I think that where the treatment is indicated, you are losing brain.
Yeah.
And yes, there are treatments where there are side effects, but we have today 16, 18 treatment. So we have to find the right treatment for the right patient, or find maybe a reduced dose or an extended dose to keep those side effects low and to save brain.
Melinda, thank you a lot for today. It was amazing. So thank you for coming today.
Thank you for inviting me.